Hey everyone, I'm Ashley Bassett.
And I'm Catherine Logan.
And welcome to Overtime with the Sports Docs. On each of these mini episodes, Catherine and I chat about a new topic or surgical technique in the field of sports medicine. We'll give you our quick take on the most recent data, ranging from operative indications, surgical approaches, post-op protocols, and most importantly, patient outcomes.
Today we're talking about slap tears, tears of the superior labrum from anterior to posterior. We have two great articles for you today that focus on the surgical management of slap tears, specifically whether we should be repairing slap tears or proceeding directly to biceps tenodesis. We will also discuss the different types of biceps tenodesis procedures, mainly arthroscopic suprapectoral versus open subpectoral. As always, links to the articles will be in our show notes. You can find these at www.thesportsdocspod.com.
Before we jump into our discussion today, we want to quickly update you on something very exciting coming up in July. And if you follow us on social media, you probably already know what we're about to say. We will be hosting our podcast series live at the AOSSM annual meeting in Washington, D.C. from Thursday, July 13th through Saturday, July 15th. We will be doing several live shows per day from within the exhibit hall and interviewing some really awesome guests about presentations they're giving at the meeting.
I'm so excited.
Me too.
Some of the guests include Dr. Robin West, who's going to be speaking about being a team physician, and Dr. Scott Rodeo, who's speaking about orthobiologics. We also have Dr. Nick Verma, who's going to talk to us about the subacromial balloon spacer, and Dr. JT Tokish, who's going to talk about the long head biceps tendon as a local autograft to augment rotator cuff repairs. We have so many more guests and episodes that we're going to be announced, so please follow us on Instagram, Twitter, and LinkedIn to stay up to date on what's to come.
Awesome. So back to our main story today, slap tears. First, what is a slap tear? So a slap tear is a lesion of the superior labrum extending from anterior, the front, to posterior, the back. There are two predominant mechanisms of injury. First is a compressive force, typically a fall onto an outstretched hand with the shoulder in abduction and slight flexion. The second and more common mechanism is repetitive traction on the arm. The anterosuperior labrum is the anchor for the long-headed biceps tendon, and repetitive loading of the biceps tendon is thought to precipitate superior labrum injuries. In throwing athletes in particular, the long-headed biceps tendon acts as a decelerator during ball release. The biceps also propagates torsional forces through the labrum during the cocking phase of max abduction and external rotation, known as the peel-back mechanism.
Classification of slap tears was originally described by Snyder, organizing tears into 4 different types. That classification system has now expanded to include 10 different types of slap tears. I'm certainly not going to go into great detail of all the different types of slap tears today, but in brief, type 1 slap is simple fraying with no detachment. Type 2 is the most common tear type and involves detachment of the long head of the biceps tendon. Type 3 tear is a bucket handle tear of the labrum with an intact biceps anchor, and type 4 is a bucket handle tear that extends into that biceps anchor attachment.
And this is important because the two papers we referenced today focus exclusively on type 2 tears because they are the most common. So treatment of all slap tears starts with non-op treatment, including rest, physical therapy, possible intra-articular injections, including corticosteroid, more for middle-aged individuals, and biologics like PRP, though data on that is limited. So, Catherine, when you're meeting someone with an isolated type 2 slap tear overhead athlete, are you attempting some non-operative treatment? If so, what are you doing?
I'm pretty much always starting with non-operative treatment, at least a trial. I usually speak to the patients about the statistics ranging somewhere around somewhere in the 30 percentile to the 70 percentile, depending on what paper you read, as who does well outside of the OR. So is that patient going to fall into that window? So I think there's 2 things that are really important when I talk to the patient. One is it's possible to do well without surgery. And 2, if you do that trial of non-operative care, you haven't really burned a bridge. That sort of benign neglect is not really going to result in furthering of injury or new injuries, unless a new trauma is sustained. So that's usually where I start, that it's a great place for patients to start with really little downside. Do you feel the same, or do you do it a little differently?
No, absolutely. And I really like the point you highlighted. And I think we've mentioned it on some other episodes too, that non-operative treatment, even if it fails, still sets patients up for an even better outcome after surgery, which I think is really important to emphasize to patients. The second thing I always emphasize is the need for patience with our patients. And so I have this flashbulb memory of being in clinic with Mark Price, who we both trained with, and he was talking to someone with a slap tear. And he was just telling them that he really encourages people to wait at least 6 months of non-operative treatment before he'll take them for surgery. And the patient's eyes just got wide because you think 6 months out of doing all the sports and athletics you want to do. But he's like, if you give this long enough and do therapy and give this time, there's a really good chance that you'll get well without surgery. I think that's really important. I tell some patients, you may not have the patience to get to 6 months, and that's your choice. It's your shoulder. But I really encourage people to try to give it as much time as possible because I think a lot of people can do well without surgery.
Yeah. And then Ashley, what do you think about injections?
I think that a single cortisone injection is unlikely to have long-term detrimental effects, right? You don't want to do multiple injections, but it's like injections into the hip for FAI. One time plus some physical therapy, I think is reasonable. I am really excited to hear more about the biologics side, and we will be talking to Scott Rodeo about that at AOSSM. I think it's a really great avenue, especially for our younger patients, but there just isn't a lot of data in it yet. We have it at our practice. I do offer it to patients. We have a non-operative sports medicine provider who does this that I can send them to, but it's not something I'm routinely advising my patients to do. What about you?
I think similar. The injection, I agree, one time is probably not going to have really long-lasting detrimental effects. I usually also counsel the patient to say, I'm not sure how helpful it'll be, but sometimes they're trying to buy a little time to finish off a season or get through an event. So I think there's a place, but it's certainly not going to heal anything or really change the long-term outcome. It's just a little bit of a Band-Aid. So I think sometimes there's a place to try it, but oftentimes I think when patients hear me say there's really no long-term great gain from it either, they get a little turned off and aren't really as interested. And the biologics I have not really employed as much for this specific diagnosis. But PT-wise, I do send them to PT, like you said. If anything, it's going to just help them get a better outcome post-surgical if that's the route that they go through. And I have the physical therapist really focus on that posterior capsular stretching as well as stabilization of the posterior scapular muscles. But there's really no sort of magic, okay, do this and it's going to get better. I think we're just trying to figure out, is it going to become asymptomatic? Is this something that's going to stop bothering you? But yes, it's still going to be there.
Yeah, absolutely. I mean, one of the papers that we're referencing today talked about that these are highly incidental findings a lot of time. I mean, how many shoulders do you scope for a cuff tear and you see a slap tear there? So I think a lot of times, as you said, with the physical therapy targeting the whole shoulder girdle, is there a chance that the true cause of the pain gets alleviated and that slap tear becomes, truly an asymptomatic incidental finding? I think that's a very good point.
Totally. And I looked up this paper recently that was in JSES, and I think it was Jang et al. Because patients have asked me, it comes up a lot because we have a lot of climbers and a lot of volleyball players. For Denver Metro, volleyball is a huge sport, and then climbers just in Colorado in general, that's probably the population as opposed to like baseball. I don't see as much. But the question I always get is, who's more likely to fail physical therapy? So looking through the data recently, what the paper I read showed it was generally the people who are overhead athletes, which that's not a big surprise. But then also, was it a traumatic slap tear? They're more likely to end up in the surgical bucket. So I usually tell people, if you decide your return to sport, if you love like running, you're probably not going to be bothered by this. But if you love playing tennis and serving is your thing and volleyball, it's a little bit less likely, but not impossible.
Did that study look at the mechanism of injury of slap tears? Because I'm always really interested in seeing, because I have patients that have a traumatic slap tear, which is not that common, but like their arm gets yanked, they felt a pop, You think, oh, it might be a cuff, you get an MRI, and no, it's actually a detached slap tear. Like, I feel like those patients are unlikely to get better without surgical treatment, maybe because of the acute inflammation or whatever it is, versus the patients where it's a degenerative or even a repetitive motion, like a peel back mechanism that leads to it. Perhaps you can more manage that. Did they look at that, or do you have thoughts on that?
I don't think so. I'm pretty sure. And I will look at it again. And obviously, if there's something in there, we can post it online.
Absolutely.
But I think it just classified it as traumatic or atraumatic.
Mm-hmm.
I think that was really as far as they got. Nice. But yeah, I do think it is, it's not like ACL tear, traumatic. We know exactly how this happened. It's just less common. And I think sometimes on the intake, we're not really getting that specific, what position was your arm in? It's just more, okay, they sort of had their arm forced away from their body and they felt, an increase in pain and potentially heard a pop or something like that.
Mm-hmm.
But yeah, I will definitely look that up and get back to you. So anything different that you're doing in PT or that your PTs have decided to do beyond posterior scapular or posterior capsular stretching and scapular stabilization? Those are a lot of I'm having a hard time getting those words out.
That's a lot of words. No, it's a lot of that. It's a lot of the same treatment we do for our throwing athletes, like posterior capsule stretching, because it always ends up being tight, right? Cuff strengthening, because it's a decelerator, just like the long-headed biceps tendon, which is yanking on the labrum. So strengthening up the cuff to act as a better decelerator. Periscapular strengthening to work on scapular mechanics so that you're not having any subtle scapular winging that's ruining the stable base for the shoulder girdle when you're doing a throwing motion or whatever overhead activity they plan on doing. So I think it's a lot of what you mentioned. And then we've mentioned this before in the past, but I'm using a lot of BFR for upper extremity. So BFR for upper extremity, there was a paper. I'm not going to say who I think it was because I'll end up getting it wrong and we're going to have to edit it again.
It was on that Chang episode though, right?
Yes, it was. It was on Eddie Chang's episode on BFR, and it was looking at the proximal benefits of BFR. And they found that they think it's the systemic effects of the growth factors that get upregulated that led to greater hypertrophy of the rotator cuff musculature, even though that was proximal to the area of ischemia. So I use a lot of BFR in these patients to work on kind of quicker and strength gains under lower strain for the shoulder joint. And it's showing pretty good outcomes in my patient population.
Yeah, no, I think that's super, super smart. And I feel like month over month, we're getting more physical therapists in our market that have higher levels of training within BFR, as opposed to just sort of the standard sort of level 1 training. I think now people are going back for more advanced things. So I'm learning more about it. So I think it's a really great thing.
That's awesome.
So you want to move on to surgery?
Yeah, absolutely.
Okay. Yeah. I don't know if there's anything else to add about non-operative, but, all right. So if we're, thinking about surgery for those who have failed conservative management, surgical treatment can be debridement, so cleaning it up. It could be repair of that slap tear, or it could be biceps tenodesis. And we should also not fail to mention biceps tenotomy, so just snipping it and leaving it. More recently, there's been a shift towards the selection of biceps tenodesis as opposed to slap repair. But slap repair remains the most common procedure in young throwing athletes. But for now, as we're going to see in our studies. So our first paper looks specifically at this patient population, young overhead athletes, and investigates the functional and athletic outcomes after primary subpec biceps tenodesis. And like you said, Ashley, this is just going to be type 2 slap tears. So Brian Waterman, friend of the show,
yes.
and Tony Romeo, they published a case series in January 2023 in Arthroscopy titled High Rate of Return to Sporting Activity Among Overhead Athletes with Subpectoral Biceps Tenodesis for Type 2 Slap Tear. They reported that 81% of patients returned to their previous level of play at an average of 4 months post-op, with 4 months is pretty good.
That's good.
There was also significant improvements in VAS and SANE scores post-op. So that was a lot. What do you think so far, Ashley?
But how do slap repairs do in this population? Well, the answer is not great. So return to pre-injury level of play after a slap repair has been reported in the range of 54 to 63% of elite throwers. In one cohort study, 60% of patients reported persistent shoulder pain after slap repair, and 50%, so 1 in 2, elected to undergo secondary surgery. Preventer published his outcomes of slap repair in an active military population and reported a 37% failure rate and 28% revision rate at short to midterm follow-up. So, these aren't great. So, Catherine, what do you think? Are you convinced? Should we be doing primary biceps tenodesis in all slap tears, regardless of age, hand dominance, activity level, or is there still some decision-making to be done here?
So I think it's a bit of a moving target for me, for sure. So I think a few things color my thinking on this. So one being my experience as a physical therapist, and this was a while ago, but this in the late 90s, biceps tenodesis was never a treatment for this, and everything was always slap repair. And in therapy, people were just so unhappy. Their pain was much better, but they were just so tight. Like things like doing their hair, washing their hair, those kind of things were even difficult because they couldn't get that end range external rotation. So I think that has always colored me as I remember that. And then we learned about all those studies of, is it 35 when we should start doing biceps tenodesis? And then it started to trend a little bit lower. And I would say I continue to have this slide towards moving towards doing biceps tenodesis in a younger population than I was doing, say, 5 years ago. So I would say I don't have an exact age cutoff, but I definitely trend much more now towards biceps tenodesis as the primary procedure, given all of this data and given the popularity of, even if they're not a pitcher or a thrower, there's just a lot of popularity of upper extremity sports in Colorado in general. Even if it's not their main sort of gig, it's something that they don't want to lose, whether it's tennis or climbing just for fun, or just volleyball, like beer leagues. They don't want to lose those sort of motions. So I've definitely trended in that way. Are you trending in that way, Ashley?
Yeah, absolutely. Absolutely. Kind of exactly what you said. And, there was this article by Hurley et al. From 2022, and they looked at patients exactly what you're saying. So less than 30 years old. So the ones we would have historically routinely said, no, this needs a slap repair. And they compared biceps tenodesis to slap repair. And at mean follow-up at 60 months, they found no difference in return to play, time to return to play, and patient satisfaction. So it seemed like it was equal, but the revision surgery rate was about 11% after a slap repair. And that increased to almost 22% in overhead athletes. But yet no patients in the biceps tenodesis group required a revision, right? So equal clinical outcomes, equal ability to get back to their sports, even in overhead athletes, but 0% revision rate. So I think that kind of says it all. If we have a surgery that's treating this condition well with a really low or 0% rate of revision surgery and getting them back to their sports, I know as orthopedic surgeons, especially sports, we want to repair that labrum. That makes sense to us. But if we have a surgery that's doing that without the need to do that and all the issues with stiffness and persistent pain and need for revision that come with it, I think we go with the better option.
Yeah, I think so too. And the other ad is, are they having any sort of sensation of subluxation or instability? Even if they don't have a history of frank dislocation, I would say that's the caveat I have. If they are closer to that 30 or they're somewhere in their 20s, even if I'm not seeing anything more anterior labral, but just that sort of sensation that they're getting, I am a little bit more worried about doing a biceps tenodesis because they don't strike me as the person who's going to get stiff. But it's a long discussion, and it's a discussion of there is a more of a revision rate that's going to occur after a slap repair. But that's what we would have to do. We'd have to go back and transition this to a biceps tenodesis. So it's not like there isn't a bailout, but it's almost like the same conversation when you're having somebody who has a big bucket handle tear, or maybe you're not able to get to it acutely and they don't come to you right away and you're seeing them a couple minutes later. You're like, okay, we can repair this because I think that's the right treatment path for you. But here's what might happen. And here's the downstream effect of what we can do. So I would say when someone's talking to me and saying they're having subluxation types of symptoms, or they have some sort of sensation of instability, that is the point that makes me wary.
Yeah. Yeah, I completely agree. And definitely in that hypermobile population. So I take care of a lot of female athletes, especially a lot of gymnasts and dancers. And so if I have a slap tear in that population, especially as you said, in a sensation of maybe an MDI type picture or even just subtle subluxations, A, I don't worry about them getting a stiff, but B, if anything, treating that slap tear and stiffening them up a little bit, not to a perceptible loss of motion as we're measuring them, but they feel tighter in their shoulder. I think they feel ultimately better after that surgery. So yeah, exactly.
Yeah, I think so too. Okay, so if we are now focused on surgery, we should talk a little bit about what technique as well as how are we actually fixing it. Technique-wise, we can do subpec or we can do super pec and do it in all arthroscopic. And then we can sort of dive into the details of once you've decided your technique, how are you actually doing the fixation? Our second article focuses on this and is titled, No Difference in Clinical Outcomes for Arthroscopic Suprapectoral versus Open Subpectoral Biceps Tenodesis at Midterm Follow-Up. So Dr. Nick Verma, who we're going to see in AOSSM, and colleagues at Rush compared arthroscopic suprapectoral tenodesis versus open subpec tenodesis for long-headed biceps tendon disease, so not slap tears. They reported no significant difference in patient-reported outcomes or complications at any time point. So, Ashley, are you doing open subpec or are you doing arthroscopic superpec or both?
The short answer is both. I'm definitely leaning more towards open subpec. I think it's a discussion to be had with patients. I think obviously anytime you're doing different, graft harvest for ACL, the different size of the incision, the different, complications, or I guess you say symptoms you can have after taking that graft, et cetera. So I have a very similar discussion with them. I say it's an additional incision, just shy, just to the lateral aspect of the axilla. Of course, anytime you make an additional incision, there's concerns about infection and wound healing and all of that stuff, and concerns for more pain in that area, et cetera. But overall, it's a very small incision. So essentially, what's guiding my decision, although I do talk to patients about it, is how concerned am I about them having persistent bicipital groove pain? And the short answer is, Catherine, and we've talked about this, I'm always concerned pretty much about everything. And so I worry about my patients having persistent pain after surgery. And if we leave the biceps tendon in that groove and they have pain in that area, is it bicipital tendinitis now within the groove, or is it just, anterior capsular, scar tissue that's causing some inflammation in that area, or just some normal postoperative pain they're working on with PT? And I don't think you really know if that biceps is left there. So I am almost always doing an open subpec biceps tenodesis to remove that tendon and attach it. However, if I have an isolated type 2 slap tear, the biceps tendon looks pristine. I pull it in from the groove into the joint space. I look at it. There's not a drop of redness, on that tendon. And they're a young overhead throwing athlete. I'll do an arthroscopic loop and tack suprapectoral tenodesis. But the majority, I'm still doing open subpec. What about you?
Yeah, I feel like this is rare. Like we are usually always exactly the same. So also doing both. And I think, like you're saying, there's pros and cons to everything. Mm-hmm. And, are we worried about the groove pain? Are we worried about, doing subpec and having some sort of length tension mismatch? Mm-hmm. Is there increased fracture risk when you're doing open subpec? There shouldn't be, but it exists. And I think there's always sort of pros and cons to everything. So I still do both. I am doing more arthroscopic technique as opposed to open. And when I do the arthroscopic, I'm doing more of an onlay intra-articular technique with a knotless anchor. And part of how I decide if I want to do an open subpec is, like you said, you're looking at the tendon. Is there a longitudinal split tear? Is there extensive tenosynovitis? And that really sort of puts me in the bucket of let's do an open subpec. The tendon health in the joint is actually not that great. So, but if you're, like you said, you have that younger, healthy type 2 slap tear, their tendon looks pristine intra-articularly, I'm going to go arthroscopic. Mm-hmm. So I would say my decision really choice involves the health of the biceps intra-articularly. Mm-hmm. But I think as everything, like it's good to know both techniques, feel comfortable with both of them so that, if you get yourself in a situation, you say, oh, I don't really know how to do those. I don't do those anymore. Like, it's just like when you hear about a patient comes to you and they said, oh, I saw this doctor and I talk to them about ACL surgery and they only do this technique, and I don't want to do that technique. It just seems like, we should feel really facile in multiple things because different scenarios call for different, different techniques. So
Absolutely.
As far as how you actually do it. So for the open subpack, you mentioned that you're doing a button, right?
Yep. I do the Arthrex proximal biceps tenodesis button. It's an 8 millimeter titanium, I believe, button, fiber loop suture, dunk it into the button, unicortical drill hole, and it's an onlay technique. And that's why in the paper, previous paper.
Go ahead. I was going to ask you if you ever did it bicortical.
I've never done it bicortical. And, the kind of the way I look at it is, and I'm going to knock on wood as I say this, but, if there isn't a problem, you don't need to solve it, right? Like stop trying to solve problems, stop trying to solve problems that aren't problems yet, right? So like, for example, with distal biceps, we've talked about this, right? I do a unicortical, now the small distal biceps button onlay technique. And, some people, they do the tunnel, they do a 2 incision. And yeah, that to me, I understand that seems like a stouter repair and things like that. But again, knock on wood, I haven't had anyone have an issue with that distal biceps repair technique. So similarly with proximal tenodesis, I don't do bicortical due to risk of nerve injury. I don't do bicortical due to risk of stress riser formation, increased risk of fracture. And for that reason, I also don't do the interference screw. Now, I know most people, I think, do the interference screw technique, which is a 7 millimeter drill hole, which to me concerns me about fracture risk, but I know a lot of people are doing that. So if that's the technique they feel comfortable with, absolutely. But I do this tiny 3-5, drill hole button in, and people have done really well with that. So that's what I'm doing for open subpack fixation. What about you?
Yeah, I think, as you said, there's always sort of more things thrown at it of, okay, now we have this new way to solve a problem we've already solved. Yes. There's lots of great options. So I do think it's a little bit of dealer's choice. With open, I've been doing the all suture or the fiber tack button in lieu of the traditional like metal buttons, but it's the same kind of thing. It's unicortical tension slide technique. And I've been really happy with that if I do subpack. And then super pack, I think I already said I use that Striker Omega where it's a knotless onlay technique. And I think that's been really straightforward. I've been really happy with all of those. And you mentioned the fracture risk. So the other thing is there's a gentleman in my sort of area, Ben Sears, who published a paper that he had shared with me. It's like a decade old out of JSCS. And they had published when he was in fellowship, like a case series of humeral fractures, and they were all in young, active, healthy patients. They weren't sort of what we get drilled into our mind, like, oh, if they're, they have osteoporosis, low bone density, be really careful with the interference screw. But these were actually like really young, healthy, good bone density patients. So I think, can't ignore that risk. It does exist, even if it is pretty low.
Yeah, absolutely.
So the other thing that we kind of glossed over that I mentioned before as an option and whether or not we would use it is biceps tenotomy. So, we're talking about young, healthy, active type 2 slap tears, but I did say it. So Ashley, do you ever use biceps tenotomy for this population?
Our listeners can't see my face, so they can't see that it's violently shaking from side to side. That's what I'm saying. But no, I always joke with my patients, like if I'm cutting something, I'm reattaching it. So if I'm going to cut it, I'm going to do a tenodesis and attach it pretty much in every patient population. But I do use that data comparing tenotomy and tenodesis and showing really no difference in terms of like strength and function and happiness and satisfaction and pain control and all that stuff. When I have a patient, and this is not really related to slap tears, but I think it's important to highlight that they spontaneously rupture from chronic long-headed biceps tendon disease, and they say, I want it reattached, and I try to talk them out of that because really the outcomes, at least according to that paper, are equivalent. Yeah. However, if we have like a young overhead throwing athlete and I'm going to do a biceps procedure to address their slap tear, I'm not going to do a tenotomy. I'm going to reattach it. What about you?
I mean, same. The only exception is we have like the luxury of doing like a John Elway sort of discussion in Denver, just because everyone knows that he, basically has a Popeye deformity. So people all sort of go, "Oh yeah, that's what that is," and they know,
That's
based
so good.
on his history. So that's the only difference in my patient discussion is there's like some local lore. But certainly not something I'm doing in this population. But yeah, I think lots of options.
Yeah.
It sounds like you and I both agree that we're trending towards biceps tenodesis, even younger populations, with the exception of just those with maybe multidirectional instability or just sort of hyperlaxity, sort of loosey-goosey type folks. But yeah, all good things.
Absolutely. Awesome. Thank you for listening to our overtime chat. We hope you enjoyed our conversation. Make sure to subscribe on iTunes, Spotify, or wherever you get your podcasts to stay up to date on all things sports medicine. If you like what you hear, please consider leaving us a review. You can also reach us by email at thesportsdocspod@gmail.com or find us on Instagram at thesportsdocspod and Twitter at thesportsdocpod, no S. Thanks, Twitter, for your character limitations. We love your feedback. Stay fit, friends.